Welcome back to the Relentless initiative, where we are always trying to find ways to help you become more educated to thrive in your mental, physical, and emotional well-being. My guest today is going to take us on a deep dive into that side of pathology where we really need some extra help. And for most of us, it is completely outside of our paradigm of understanding. So we put 100% trust in the practitioners that are looking at us and observing us, and we're kind of left up to what they see as to how we move forward with our individual pain, pathologies, whatever we may have. So my guest, I'm going to call him KJ. KJ, you tell everyone what your name is.
Yeah, my name is Kjetil.
Not coming out of this Tennessee mouth.
Come on.
Not going to happen. Not going to happen. So I'm going to call him KJ or Mr. Larson, but his business is, and I want to kind of go to the backstory of how you started your company and your business was because of your own need of needing imaging, needing further, care and exploration into why you were hurting because you weren't getting help. So MSK Neurology is your company. And just to put it in layman's terms, I guess the best way to put it would be that you give a second opinion when the first guys that came in didn't find anything or they didn't do it the right way. And you kind of come in with people and go over their imaging or ask for new imaging to really get to the cause of whatever symptoms they may be having. Is that kind of a good generic description of what you do?
Sure. Well, I guess a lot of clinics operate that way, that they give second or tertiary opinions. But yes, sure. Okay. Yes, I have a little bit of different approach, I would say, than many of the conventional service providers, simply because of my background.
Right. And what I would like to show everyone. So this is just a quick look at his website, and I can't stress enough, I'm a body worker, so that's what I do with my 9 to 5 is I'm in clinic, palpation, working on clients all day, every day. And I too see, I've seen this specialist, this practitioner, I've gotten this diagnosis almost every day. I'm like, your shoulder is being caused by your right hip. Did they talk to you about your right hip? No one said anything about my hip. So I kind of have to go through your whole body is connected, So with my clients, I'm trying to always teach them, you have to research this stuff on your own. So if you're having symptoms, you're having pathologies given to you that you have, but you're not getting long-term relief or care, you have to start investigating it on your own. Now that can get slippery with the whole WebMD diagnosis of myself, but you also want to take advantage of the information that's out there, and you have a plethora of information for people to dive into on your website. So this is just a sample of the articles that you have. I know headaches are a big one for people. So if you are an individual that either can't get to certain care or have questions about the care that you've gotten, he has on his website and his social media just case study after case study after case study of this person came in with this, and then looking deeper into it, this is what I found, or they were diagnosed with this certain thing, but by the way, that's really not what they had. So please go to his social media and his website and just start looking into what is really the problem. So that quick view of his website and his social media page is a great place to start looking for more information about something you may be dealing with. But I want to kind of go back to the beginning, and I'll share first kind of my own story about an imaging situation. And then I want you to tell everyone your story of how you started in this whole new career that you have. And this is such a common story I hear, because when we go through things individual like this, we're like, I've got to tell everybody else now of what I learned. So my own personal story of this is, I was working at a spa for several years before I went solo, and I was a body demo for a new tool that the spa was considering getting to use in sessions. It was called the Renoodle. Have you ever heard of that?
No.
It's ridiculous. I know you already know that. So it was basically, it looked like a pool noodle with divots cut into it. And the idea was for like static pressure release on other parts of the body while I was working somewhere else. So put it under their hamstrings while they're face up, or put
right.
So so you use it as a static pressure tool while you're working somewhere else. So it's a gimmick, you know. But I was the body demo for that product, and it was under my hamstrings, under my thoracic cavity on my back, and they didn't have anything under my head. So my head was laying flat on the table for about 15 minutes, and it didn't hurt while I was doing it, but I have historically straight cervicals. So I've lost some of that curve we should have in our neck. And about 4 hours after I was laying like that, I started getting severe pain in my C7 area, that little bump on the back of your neck. Mm-hmm. About 2 hours after that, I'm pretty thin person. It looked like I had a dowager's hump on my back. It was after 15 minutes on that bench. Yes. It is very strange. So it began to hurt extremely bad. I could not rotate at all. I had absolutely zero motion in my neck. So of course I went to HR and told them what happened, and they're like, that couldn't have happened from that tool. I'm like, nothing else happened to me today different than any other day. So being in a corporate environment, I had to follow a protocol. So I had to go to urgent care, and they demanded that I take like a muscle relaxer and a painkiller. And I refused to take the muscle relaxer because unless absolutely necessary, I just don't like taking medication. Right. So I told him I would take a more holistic form of a anti-inflammatory, and they said that was okay. So I had to do that for 6 days before they would send me out anywhere else, because I had to follow this protocol. And then they sent me to a physiatrist that did an x-ray, and this was his intake. Well, it seems like you have some cervical tension. It's like, yep, sure do. Yeah. That was his intake. He looked at the x-rays and said, well, you have kind of loss of your cervical spine, but I don't really anything that would be causing what you're having, what you're presenting with. He was like, and we had this long conversation, and I obviously let him know I kind of knew a little bit about what I was talking about. And he said, well, I'm just going to refer you to PT for your neck, but just so you know, you might teach them a few things while you're over there. I was like, well, I'm not going over there. I'm not going to go to PT where I know more than they do, and I don't know how to help myself right now. Yeah. So what I ended up doing was, I knew a man that was he helped start a couple massage schools. He'd been in the industry for years. He did craniosacral therapy. So I just went to him every week for about 6 weeks. I had to take 2 weeks off of work because I literally couldn't move. Yeah. And that was kind of how I treated it, and I kind of got better. But it was interesting, over the first 2 or 3 years after that, every time, if I would be like undressing, taking my shirt off, and yawn at the same time, it would slip out, and it would freeze out for like 3 days. So interesting. Yeah, I know, it's really weird. So that was kind of my only imaging story that I have, but it was just that whole, I'm here and in desperate need for you to help me figure this thing out, and you don't have any answers. So it was just very frustrating. And at that time I had health insurance, but if you don't have health insurance, you can't just keep going back for all these tests to figure out what you should be doing. So that's my story. So go ahead, comment what you think about the cervical thing.
Well, first of all, an x-ray is just to exclude a fracture, right? An x-ray is really, unless the fracture is significant, it's not always easy to see a fracture on the x-ray. Mm-hmm. So an x-ray was not an appropriate scan for this kind of issue, first and foremost. Now, on the actual occurrence itself, if the device, or whatever it was, how big it was, I don't know, but if it was under in your thoracolumbar junction, I agree, it shouldn't be affecting your neck to that extent. So there probably was some kind of intake morbidity, or some kind of pre-morbidity. All right, now exactly what it was, I don't know. Might have been a disc issue, for example, or a C7 issue is not that common, but it might have been.
So the point being,
it's gotta be up to you,
is that person, that specialist, that practitioner didn't take the time to do all of that. He just said, well, I don't really see anything on the x-ray, so I'm just going to send you to PT. that's the problem.
Yeah. Well, I mean, it depends who you come to, right? Because they could have done a facet joint injection, for example, diagnostic block or whatever. Especially if you had a swelling there, it would suggest that maybe there's something with the facet joints. So I don't think it was a muscle tear, so maybe it could be inflammation of the facets or something like that, or a disc injury. You can go to a surgeon, you can go to a PT, you can go to a massage therapist, and sometimes you will get the better help, not necessarily depending on the education that the person has.
Right.
It comes down to the personality and the clinical experience that each practitioner has, really.
Yep.
Yeah.
So tell me about your story, the pain that you were dealing with in the beginning of what started your career that you didn't find help for. What was that?
Well, for me, it just started with a left knee pain, like a jumper's knee. And you know what shocked me? My background is in electromechanics. So I would say I have a pretty good mindset for like clear-cut mechanical thinking, basically. Jumper's knee basically on the left knee. And when I Googled this, it seemed to be the most common issue ever. And yet, when I went to seek out help for this, the intervention simply didn't help. Like do squats. And, squats is what got me into this in the first place. Yeah, I'm not gonna do squats, buddy. Well, just gotta have to wait and see what happens. Yeah, well, I already did that. So back and forth, I tried to find some kind of explanation for this, and I had more pain on the left side than on the right side. So I remember this one day I was just kind of fiddling around trying to think, well, there has to be some kind of difference between these two pieces of shit, right? Because one of the knees was super painful and the other one wasn't. The right one was quite bearable, actually. So I was just palpating my knees. I had my knees straight. I remember this, and I know it's too bad I don't have a model here, but I noticed that the tibial plateau was basically more forward. Tibial plateau was more forward on the side that I had the pain. So I figured, all right, maybe this is some kind of friction problem. And in later years, I've been finding some radiological evidence for this. But at the moment, I really had no clue. I just noticed the difference, and I went online to Google. So I figured, all right, if the shin is forward, then there has to be some muscles pulling it back. And I realized, like roughly, that rectus femoris is what pulls it forward. Like a half truth, but rectus femoris pulls it forward. Of course, the ACL also prevents it from coming too far forward. And then you have the popliteus and the hamstrings basically pulling them back. So what I did, I started to do a ton of hamstring work, like hamstrings 3 times per week, 20 sets of 20, lots of hamstring. And I did some popliteus training, and I was stretching my rectus femoris. And interestingly, what I found was that as that tibial plateau, it did actually become less prominent. And as it did, my pain levels also came down, which to me was a breakthrough, because I had been suffering with this problem for a year already. And ultimately, this is what got me back to doing squats without pain. Now, the next issue I had was left side of shoulder pain, a shoulder impingement problem on the left side. And it got to the extent where I could not even lift like 20 kilos on that side. It was very impaired. And once again, when you Google shoulder impingement, it's like one of the millions of hits. You will find millions of hits on this topic. But then regardless, when you actually try the advice to fix it, it's bullshit. Like it doesn't work. Like trainius ratus anterior. All right, well, that might sound nice and dandy because the serratus anterior causes upward rotation and posterior tilting. The problem is that patients who have shoulder impingement syndrome, they also have scapular dyskinesia. So if the shoulder doesn't rotate properly, if you try to train the serratus, it's not going to work. You're going to train everything else. You're going to train the pec minor, the major scap, and whatever. So it was a lot of back and forth. Basically, I was not able to find any good solution for it until I came over the work of a very interesting guy. His name is he's a very humble guy. His name is Dr. Evan Osa. He's a chiropractor. He's more like a physical therapist, really. He's not really a chiropractor, I would say, in the way that he works. But he's a very brilliant guy, very humble guy. So perhaps when you look at his videos, he doesn't really get the fame that he deserves, in my opinion. But he's a brilliant guy. And he had all these videos. Everything was for free. All these videos about how the shoulder should move, scapula should move. the function of all the muscles around. For example, how it's important to train the subscapularis, which I had never heard before from other practitioners. And I basically, not only that, but also the resting height of the scapula. The scapula should not be resting down like a lot of people think. It should actually be resting in mild upward rotation, which is a trap problem. So I started implementing these things into my practice, well, into my gym routine more precisely. And slowly but surely, I was able to reverse this dysfunction. And was basic. So in brevity, I was able to fix these two problems on my own, whereas when I was seeking out therapeutic help for this, no one was really able to help me. And that made me think a couple of things. First and foremost, if this is such a common problem, why the fuck cannot anyone help me? Like this is not good. And why are we having these millions of articles saying just to external rotations when this is a much more complicated problem?
Yeah.
And then we have this dumbing down. And then the second problem, you have this tremendous dumbing down and then claiming that it's the truth. Just do this. And they know it doesn't work.
Mm-hmm.
So that's a big problem. And we're back to what we talked about earlier. Chronic pain, you asked me why didn't the physiotherapist examine you better? Well, chronic pain is a black hole in medicine. No one else likes to talk about this. There's no good consensus with regards to pain other than really psychosocial factors. Like don't smoke, have good income, don't have anxiety, don't be obese. It's very, very vague data. Very vague data that is misleading a lot of practitioners. So then we're left with kind of, all right, don't make the patient feel like shit and kind of do whatever you feel is right because it doesn't matter, it's psychological anyway. And that's really a fucking tragedy, isn't it?
Yeah.
Blatant tragedy. It cannot be like this. And I think things that's turning now slowly but surely. A lot of people now in PT school, they're not buying into this nonsense that none of the examinations that you do matter, orthopedic tests, they don't matter, and so on. A lot of people are not buying into this. All low back pain is psychosocial. I mean, come on, that's a joke. If that was true, why would you be operating patients for low back herniations, disc herniations in the hospital? Yeah.
You bring up a couple of really good points that I want to hit on for a second, because one of the things that you did was you looked at your own body. You just took the time to look at yourself and look at this side compared to that side. An individual that has zero training in anything like that or anatomy knowledge, just look, just feel. I had a client bring her son to me once that was having knee pain and was going to see several different practitioners. And one of them was doing the scraping. What is that? Yes.
That's some bullshit.
I know that. And so I was like, okay, you have to be careful with people because they trust this individual that they're going to see. So I don't want to automatically say that person's full of crap. But so what I did was I had him sit on my table and put both of his legs out. And I said, put your hand on this quad and put your hand on this quad and just feel it. What does your hurt leg feel like compared to your not hurt leg? He's like, well, my not hurt leg feels real. I can feel the muscle really good. And my hurt leg, I don't have any muscle there. I'm like, and you keep going back to have it scraped on every session that you go to. Probably not a good idea. We need
a lot of sense.
Yeah, we need to build that muscle up. You're making the muscle even more and more fatigued. So they're like, oh, well, that makes sense. So, but you can do that on your own. If you're going to, just because someone has a license does not mean that they know what they're talking about. They found a new tool. They went to a new continuing education class one weekend and got a new little thing to try. And they're trying that thing on everybody because it looks cool and it's different, cupping. And, it doesn't mean it works, So
it's like I said, there's no consensus. No one likes to talk about this, but it really is, there's no consensus.
Because you have to look at each individual as they are presenting with their backstory and current situation. And unfortunately, in our medical paradigm right now, most practitioners have to see so many people per hour to keep that machine running. Yes. So they don't have the time to investigate what's causing your issue.
I agree with that. And there's also another thing I would like to point out, that there's so much, how would I say, there's a lot of people who stick their noses out and say, well, I think I might know what's causing this. Let's say a low back pain or some other difficult subject. You will get a ton of haters coming out. No, you don't. No, you don't. Evidence is clear, blah, blah, blah. And this makes a lot of people, especially if you're not a very, very aggressive person, it's going to make most people be a little timid and pull back, regardless of maybe their idea was great. The idea might have been spot on, but that aggression from the naysayers come and bring you down. That's also a very negative factor within academia, that if you bring out some kind of notion that is outside of the, politically correct way of thinking within the profession that you're in, you're going to be bombarded with all kinds of crap.
Yes.
And that's another big problem. Lots of very, very intelligent, clever guys out there, and women for that matter, are being bombarded when they put their ideas out. It's a big problem.
Yep. And unfortunately, the average person, not non-clinical person, they don't learn that until they've been through like 4 or 5, 6 years of the other way and it not working and getting worse. And that's how I get a lot of my clients, is they come to me after years of all of this stuff and they're just like, can you just make me feel good for a few minutes and just give me some relief for a few minutes? And then I end up helping them with my lack of knowledge compared to their other people more than the other people, because I just look at their whole body. I look at their whole body. I listen to their story. I try to figure out how to help them move without hurting, because like you were saying, you have a protocol you're given if you have this knee pain. Well, when I do that thing, it hurts. So I'm not going to do that thing,
So then either the diagnosis is wrong or the protocol is wrong. Right.
Yep.
If it's not working, you're doing something wrong. If I'm treating someone and they're not getting better, and I know, let's say I'm not 100% sure, because there might be some explanation why they're not better, right? But the honest thing to do would ask yourself, well, am I 100% sure this diagnosis is correct? Do I really have the willpower and the integrity to go back to square zero and recheck my own work? Because it takes a little bit of courage to do that, because you might find that you're wrong. It could be, that you would have to tell the patient, listen, I'm very sorry, but I made a mistake. And a lot of people are not willing to do that.
No, that's not going to happen with most white
coats. That's a problem. And here's what I have, because most patients, they're gonna be happy if you tell them, listen, I need to recheck this because something doesn't make sense. I could have made a mistake. I'm not sure. We got to check it out. Now, if it turns out that I made a mistake and I complain, I will fire that patient right away. Like, get the fuck out of my office. Like, if you think that I never make any mistakes, then you're a fool. Go back to whoever you were treating you before, and have them tell their pleasant lies to you. Like, I would not accept that. If you cannot accept that I'm human and that this is not an exact science, then get out of my office. But I find that most patients, they will be happy that you were humble enough to go back and check on your work, because you cannot be right all the time. And to be able to grow as clinicians, we have to be able to go back and recheck our work, especially in complex cases.
Yes. Yeah. Well, and but again, the average person, their idea of a body is like skin and guts on top of bones. That's all they know. Like, most of my clients don't know they have muscles in the front of their neck. Like, oh, that's a muscle. So they just don't have any idea. I was going to say, what you were saying, being willing to work with your client and then being understanding, you're researching their body, and it's going to take more than one session sometimes, probably many.
Sometimes, yeah.
But versus I had another client come to me with hip pain and was seeing great progress, and all of a sudden had some issues come up and it got worse. So she went and had some imaging done.
Yeah.
And they said, well, and I don't know the exact diagnosis, it's not really that bad right now. So we don't really have anything to help you with until it gets bad enough for surgery.
Well, that is accurate. That is accurate. They're basically saying this is nothing to operate right now. So you need to go back to PT and get the proper help there. So
but they didn't offer any of that. They didn't take that next step to help her decide what she needed to do. So that's what my point was. Be with a practitioner that is there to investigate, learn your body, find the next step, no matter what, and to keep going until they find what works for you. So I want to get into helping people when they do come to that place where they find their care isn't working or the pain is so debilitating, it's taking them out of their life, you know, on a long-term scale. They have to go for imaging. Again, it's not anything any of us think about until we're there for that appointment. So we have absolutely no clue what imaging should be done, what the downfalls or what can be missed in this type of imaging versus this type of imaging versus you should have been laying down in this one, you should have been standing up in this, and I should have had you turn to your head. So there's all of that can go into play with getting imaging. So can you kind of just walk us through what the most common imaging tools are right now and what each one does help with or lacks in its observation?
I mean, it's not that easy. It's not that simple. So first and foremost, if you don't suspect that you have a fracture or something sinister or cancer or something like that, the most useful imaging, it tends to be spinal imaging. More precise, it tends to be low back and neck. Like on a pelvic MRI, if you have a musculoskeletal problem, generally not a lot to be seen there. If you have a muscle rupture, you will be able to see that. Bursitis, you will be able to see that. I find that the pelvic and hip MRIs, they tend to be misleading in many circumstances because let's say with hip pain, a lot of patients with chronic hip pain, they have nerve pain. You don't see that on MRI. Like you don't see that unless there's a tumor. You're not going to see that. So the MRI might come back and shows coincidental findings, which, maybe some hip arthritis, labral tear or whatever. And now it's up to the clinician to determine, well, does this fit with the clinical presentation or not? And that's very, very important because the radiologist never saw the patient, right? He doesn't know. So he's just looking, well, this is what the images show. And now you have to do the clinical correlation. And a lot of people don't know how to do that. And this is why I always ask the patient, like the 3 W's, where, what, and which. So exactly where is your pain? Exactly. What kind of pain is it and which movements induce your pain? Now, just based on those 3 questions, if you have some anatomical and pathological knowledge, you will be able to narrow it down to some more generally 2 or 3 differential diagnoses. And now you know where to start versus calling it, well, my pain hurt, my hip hurts. Yeah, that's not useful, buddy. That's not useful. Mm-hmm. We need to be able to narrow it down. It's very, very important. All the time I get, I can give an example. I had a guy come to me, he was like 16 years old, soccer player. Chronic pain in the ischial tuberosity. And he had been diagnosed with chronic hamstring tendinosis. And he had been treated and spent thousands of dollars on treatment. He had PRP injections, which, $700-800 per hit. To no avail. So the first thing I did, I palpated his hamstring. There was no pain. Listen, if you have chronic hamstring tendinitis for 1 year, yeah, that's going to hurt when you touch it. There was no pain. I touched the the ischial tuberosity, hamstring insertion, no pain. So I told him, and then I did a strength test like I did a hamstring test in the muscle. And certainly if you have a hamstring tendon problem and you tense up the tendon, you're going to have some pain. No pain. So I said, well, this doesn't make any sense. This is not a hamstring problem. And it turned out he had ischiofemoral impingement. He had hip impingement. So this is a hip impingement problem. We treated for 1 year for hamstring problems. So, if you don't, we have to go back and confirm our theory. That's basically what I'm saying here. And we need to have at least some logical approach to be able to confirm or reject our theories. You cannot just look, well, it hurts there, let's treat that. Like kind of the Grassen approach, like, oh, you have pain there. I had one patient, it was crazy. I had one patient, he had pain in the side of his arm. And listen, people, unless you're a bodybuilder taking tons of drugs and it happened during a bench press, You're not going to have a triceps muscle inflammation. Like maybe if it's after a shot or something, but like an infection, but you're not going to have it. Generally, brachialgia tends to be a nerve-related problem. He went to see a PT. The PT found a trigger point in the lateral arm, and of course, this was the radial nerve, right? So he did a thorough job with the trigger point treatment on this trigger point, and 10 minutes later, the patient has a wrist drop, radial nerve palsy. This stuff is not, well, who knows how common this is. So we have to ask some questions, and we have to dial it down to some rational differential diagnosis. Patient comes in with arm pain. All right, so what is the likelihood? Could it be a fracture? Sure. So we ask them, well, did you have a fall on that arm? No fall. All right, so what is the likelihood that this is a triceps inflammation? Very low. Very, very, very low. So more likely it's going to be some kind of nerve problem, for example. So you just got to dial it down to just ask some good questions and dial it down to what is the most likely. What are the most likely differential diagnosis? And then, of course, you need a workup plan to work out each differential and which one has the most evidence, clinical evidence to support it.
So when a person has a pain in a certain joint and their practitioner's first answer is go get it x-rayed, and x-ray comes back fine, I don't know.
Well, it depends what joint it is.
Yeah.
So it depends on a lot of problems. It depends on a lot of variables. How long have you had the pain? Did it come after trauma? If it came after trauma, all right, you should have an X-ray, maybe also an MRI. For example, it really depends on a lot of variables, and who is the best to determine what kind of imaging you should have done. Well, it should be your primary care doctor, but oftentimes, they don't know a lot about imaging. So really, the best to ask is after radiologists, but they don't see patients too.
Right. There
you go, right?
Yeah.
So this is why I say radiologists should start seeing patients. It will solve a lot of problems.
I had a client that I forgot what her diagnosis was, but she couldn't swallow. She could hardly eat any food anymore. Is esophageal something or other. And she was having surgery on her. I don't know exactly what it was. She was having 6 different surgeries. My question to her was, well, has your surgeon looked at all of the other factors that are going on with your body? And she's like, well, I haven't talked to the surgeon. I'll just see him on the day of surgery. I was like, he's the one that knows the most about that part of the body. And it's really the hierarchy of how this process works just seems really odd to me, because you go in for the imaging and that person is not like my daughter had to have an MRI for her back. She hurt her back in college playing volleyball. Mm-hmm. And it's like they walk in, they put you on the table and the guy's over just like looking at his phone or whatever. So he has no association with the patient. And then he takes the imaging to someone that reads it and they give a diagnosis. And if you have to have something done, that person does it. And I'm like, they're not connecting all of these things together. There's going to be a lot missed in that process.
And this is why emergency medicine tends to work very well, because in emergency medicine, all the clinical, usually, not always, of course, but usually all the markers are easily identified. In chronic affliction, any kind of chronic affliction, you need a good clinical correlation. This is usually where both the imaging, but also clinical workups come short, because I also always say that when radiologists should start seeing patients, start asking them questions and whatnot. But clinicians, they should learn to read at least the basics of imaging within this scope of practice. Basics. So let's say you're a physician, you should be able to read the basics of hip and spine and whatnot. Because a lot of the time, and this is not because of the quality of radiologists necessarily, but in radiologists, they have this huge list of stuff that should be done yesterday, and a lot of times they have so much pressure on them that they're not able to say no, basically. So you're going to end up spending 1-2 minutes per study, and this way you can end up missing a lot of important things. I've seen numerous incidents where large disc herniations are missed, for example, large ones. I examined a patient that have paresis of the triceps, near paralysis of the triceps. Checked the MRI, and sure enough, large C7 disc hernia. Missed. MRI report that's normal. This is because the radiologist is a clown? Well, not necessarily. It's just that tremendous pressure to just swoosh through everything. It's a big problem, and that this will be solved if we, at least in chronic medicine, or in chronic pain, or in recurrent images, that you actually set up a consultation with the radiologist versus repeating the study.
So how do you think that was missed? Like, where was the hiccup in the process that something that obvious was missed?
They didn't look at the images. So
they were just thinking here, and they didn't look at everything connected to it. No,
it doesn't work like that. So you basically have an neck MRI, okay? And you can look in the sagittal plane, you can look in the axial plane. Now, how does this happen? I don't really know. But obviously, some people think that, well, it's a little complicated, but in the low back, it's a little bit different. In the low back, the foramina, they're at a 90-degree angle. When you look in the sagittal plane, you can see the foramina, you can see the root output. In the neck, you cannot. They're at a 45-degree angle. So in the neck, you have to look at the axial images, because the central canal can look impeccable, and you can still have a big fucking disc herniation crushing your nerve roots. And if the radiologist doesn't know that, then we're going to check the axials. They will just kind of skim through the sagittal. Yeah, it looks all right. And you just copy paste, normal age-related degeneration, no problems. Now, I really shouldn't be saying this, but fuck it. It is what it is. Right? It is what it is, and it needs to be done. It needs to be dealt with. And I'm not saying everyone is doing this, but this is certainly happening. And I've seen unfortunately, many circumstances, incidences where this has happened. And it's not because I'm better than them or anything like that. I just have much more time. This is why I have patients paying for my time versus just consults. You want more time, you pay for it. Simple. It's a win-win situation.
Yeah. Instead
of working on this quantity-based approach, obviously, if the same radiologist had the patient there in the room with them, had a description from a physiotherapist saying there's weakness of the triceps, well, they know that that's a C7. Well, let me have another look. Patient is right there. You can see that they're obviously in pain. This is not just some bullshit MRI that was ordered. You go through it again, and there you go. Mm-hmm. Right? This doesn't take problem solved. So I'm saying this is usually not a competence problem. It's because they're not seeing patients, and there's too much. They're forced to do too much work in too little time.
Is you have to, as the individual, have the courage to keep pushing for answers and to keep asking questions. So you have to, especially while you have that practitioner there with you in the office, you have to, even if you can see that they're in a hurry and they're frustrated, you have to demand their time and attention beyond you, even if it's frustrating for them. So that's
not a good idea. No, that's not. So if in one way I agree with you. In another way I don't, because if you do that, demanding doesn't work so well when you're working in an environment where there's a high ego. All right. If you go to a surgeon's office or doctor's office generally and you just start demanding stuff, they have 1,000 other patients. Like, get out of my office. I don't have time for this. They might say it in a nice way, but you're not going to get anything back. So the best way is it's all about money. The best way is to say, look, I see that you're busy. Can I come in at a time and pay a little bit extra, and we can use some more time on this? That's the best way to go. Raising your voice. You always hear about this one guy who is in the hospital. They slam the hand down and say, I demand respect. And if someone fucked up, and let's say they have a fracture or something, that might actually work, and you will, we're very sorry, and whatnot. But generally, it's not that simple, and you're just going to make the doctor dislike you, and you're going to end up being stapled as a difficult patient. And that's not going to, if you have a chronic problem, especially something that ends up needing surgery, that's not going to help you, my friend. So it's better to be polite and just show it's all about the money. Tell them, listen, I can come back when you have better time. If you have faith in the practitioner, if you don't, find another one and pay them, obviously, right? Yeah. But just pay for people's time. Best way to go about.
Yes, I agree. And if you, even in massage, I hear this all the time. I wish you took insurance. And I know these people and I see their social media and I see where they're spending their money. So we as individuals are going to have to put our health as a priority and maybe not go on vacation this year and find the right practitioner that can help with our severe pain that we're constantly dosing with pain medication with. So that becomes an individual choice.
I agree with you. I think that, there's always going to be some people that don't prioritize maybe the way that we would like them to do. And I think that's fair enough. If you have pain and you can live with it and you just come in now and then to get the fire put out, if that's your choice, but don't complain. Don't complain to me. If I tell if I give someone homework and whatnot, and they don't do it, and they come back and they're happy, I didn't really do what you told me, but I'm happy, I'm still back, I still trust you. They're honest and polite. All right, buddy. Thanks for being honest. Let's try again. But if someone comes in complaining and they haven't done what I told them, my temper is going to be real short.
I had to fire a client in the last 4 or 5 months because it was every time they would come in, it would be an argument. It was an argument every time because no matter what I gave him or what I offered him or how I regressed it or how easy I made it for him, he just wouldn't do it. But then he was still angry. And no matter what I said, he always had a reason why that wasn't right.
What was the problem?
He was a hockey player, was in his late 50s and probably had impingement, but he wouldn't do any. Yes.
Hip impingement, yeah.
Yes, but he wouldn't do anything to try to help gain mobility in the joint. He would tell me why everything I offered him was wrong. It came down to, I'm sorry, I can't help you. And I don't need to start my day knowing I'm going to have a fight on my hands with you. And I have 5 clients after you. So that was how I handled that situation.
What I would do in that situation, first and foremost, it would be very interesting to look at the patient's images, right? Because this could have been, I haven't examined them, so I don't know, obviously. But let's say this was a surgical case. Well, then you could tell the patient, listen, I don't think this is going to cut it for you, for example. I could be wrong, by the way. I don't know because I haven't seen this patient. But maybe you should go to have a talk with your GP and have a consult with an orthopedic surgeon and just to find out if this is a surgical case or not. If it's not, come back later, we can talk about it. If it is, then it can be found out. This is one way to approach this. So that here's, this is kind of like, is it called pet peeve? Is that how you say it? It's kind of an important topic for me. And that is patients who are not candidates for conservative treatment. We like to say, and this is something that really fucking angers me, to be honest with you, because you like to say, and it makes sense to some extent, well, surgery is the last resort. No, it's not. We have to look, what is the actual prognosis for what we're dealing with? And how do you evaluate? Well, unfortunately, most clinicians, they don't have the knowledge to evaluate that. It is the surgeon that has the knowledge to evaluate whether or not it's a surgical problem. But this is really something that, recognizing yellow or red flags, not necessarily with regards to, oh, you're going to die tomorrow. That's not what I'm talking about. But yellow flag in respect that this is not going to be, no matter how compliant the patient is, you're not going to be able to deal with this. Mm-hmm. Right? And that's something that's very, very important to figure out, because the patient could be spending, I've seen patients spend tens and thousands of dollars, and it turns out they need surgery. Yeah. And no one told them. Even it was one chiropractor that told the patient, well, I don't think you should have surgery, but that usually doesn't work out. It is simply not true. Let's say you have a hip impingement. Well, if you have hip impingement in early stages or moderate stages, you can just go in with a peak-hole surgery and you can snip off those lesions. Now you prevent the arthritis from happening, and you can do beautiful conservative, post-operative conservative treatment and get amazing function of the joint. Versus trying conservative doesn't help because the joint, there's too many lesions, there are arthritic lesions. You keep going with it. There's very restricted joint movement. Eventually you have full arthritis and you need to do full hip replacement. Now, what is better, arthroscopy, like a peak-hole surgery, initially, or wait and have full hip replacement? Obviously, I'm putting this on the edge, but in many cases, this is reality. We should have you should learn the basics of how to identify patients who are outside of who we can help. And we should also try to build relationships with the surgeons.
Yeah, it's a huge topic. And not only in the physical realm, but in the psychoemotional. So, again, with massage therapy, I have most of my clients coming to me, or not most, I say 50-50 with like functional issues and just stress related issues. And I do craniosacral therapy, and that's a great way to help calm the body down.
Uh-huh.
And they start, I say this all the time, when I start touching people, they just start talking and telling me all this stuff. And I'm like, that is way outside of my scope of practice. And I refer out to therapists, psychotherapists, psychologists all the time. And if we as a body of practitioners would get more in line with that way of thinking, we could truly help our people. And it's so right. And another point to make with people is you can't just have one road to health and one road to recovery and one practitioner that's going to do it all, because they have their specialized thing that they are concentrated on to help that area. So you're going to have to invest time and resources into your health.
Yep.
Yeah.
Yeah, I absolutely agree with you.
Yes.
And I mean, it's like, and I think with the psychological stuff, a lot of times the patient might not expect that you're going to fix them psychologically, but they just have faith in you and they will share it with you like they would with a friend. They don't expect a friend to cure them, but they just have faith in you. So I think it's good to also declare, like, how to say it in English, kind of clarify with the patient, listen, I'm happy to talk with you about this if you want to. This is not my true scope of practice. I'm not an expert with this. I know a little bit. I know some stuff, just so that this is clear, but I'm happy to talk with you, and we can talk about this if you want. And if they agree with that, fine, we can talk about whatever the fuck you want. You're paying for my time, so no problem. Yeah.
Yeah. One of the greatest stories that I have that I tell everyone is I had a client that was coming to me. Actually, this story I tell a lot. I had two mothers, both around the same age, both had 4 children, all by C-section, both had chronic low back pain, just like super similar presentations. Yeah. And I do the same dialogue with every client. I talk about the body, I talk about the mind. And I work out on the abdominals, I work on the hip flexors, I work on the scar tissue, all those things. And when I'm doing that, I'm talking, we're talking about life. And this one client just was ready and willing and there and did all the things I asked and did really well. The other one, not going to happen. She was in that codependent relationship with her family where her pain was like a punishment for them. And that was a interesting paradigm. Yeah. But the one lady that took everything I was talking about, I was talking about muscle compensation with her body. And she was like, you know what? I'm the compensator for my family. I need to stop doing everything for everybody. Yeah. So that was pretty cool. So.
Yeah, that's very interesting. Yeah. I think if you have the person, usually when people like open up, most patients don't open up to me because it's kind of obvious.
I don't see why not.
I don't really have some like, I would say maybe some weird patients, they open up to me because I'm strange too, right? But most patients, they don't really open up to me. When I say, I just kind of refer them out. Yeah. I forgot what I was going to say.
Well, the point was being cooperative in the industry. Yeah. So, that's not your strong suit, but you have the knowledge to say, hey, listen, and your intuition, and you work with so many thousands of people, you can see when it's not just a functional issue, there's something else there. And you're like, hey, you might want to go talk to this person.
Exactly. But this is what I was coming to. In your case, you obviously, you have a more pleasant personality than I have. So it's easier for the patient to open up to you. And in those circumstances, and obviously by practice, if you practice, you learn how to improve yourself. And psychology certainly is not an exact science. That's for sure. So if you are able to dig, by talking to the patient, you're able to dig into those deep sides, deep problems, then I think there's no way why you shouldn't continue doing that while also doing the body work. And that could absolutely help the patient, very much so, because the confidence between the clinician and the patient is so tremendous, absolutely tremendous. importance for being able to patient to open up like that.
Yep.
So good job.
Thank you. There's a book, Mind Over Medicine, by Lisa Rankin. She's I think she's a gynecologist, but she left the professional field and went solo because she was having that pull of wanting to spend more time with her patients and seeing that this patient didn't need this surgery or needed this other surgery. And the top dogs were like, no, this is what's on the books today, so you're doing that. And so she had this internal struggle and finally left the corporate industry and started her own practice because she couldn't do that anymore.
Which is fine. Yeah.
Yeah. And that's why when I made the point earlier of the individual being empowered to see those things and to know when to remove yourself from someone's care, or, just to have a better dialogue and ask more questions, I think is what I was getting at. So back to the imaging part. So the x-rays and the MRIs, what other type of imaging? Because I know you do some different things as well.
Well, I mean, let me tell you a little bit how I got into this, because actually I was treating a lot of thoracic outlet syndrome patients. Now, this actually turned out not to be true, but there are like 5 or maybe 6, 7 studies back from the 50s and 40s up to the 1990s that show that rotational vertebral artery obstruction or even dissection could occur in patients with thoracic outlet syndrome. So I was worried because I knew that some of the treatment I was doing was provoking the patient in the beginning, and I was fearful that this was actually strenuous for the vertebral artery. So, and I was sending some of these patients out to a radiology clinic here in Oslo, and every single time they said, well, everything is normal. And in the beginning I trusted it, but then eventually I'm like, on patient 10 or 15, I thought, that doesn't sound right to me because the patient is obviously not fine. So I decided to get an ultrasound machine and to learn vascular ultrasound. And this is not a very common thing to do, especially for a musculoskeletal worker. But my motivation for this was basically I don't want to kill my patients. How can I avoid kill my patients? Because I wasn't going to stop treating them. So I need to ensure that I could treat them safely. So I bought an ultrasound machine, and then I bought the books and whatnot. And you cannot really learn, especially the vascular part, you cannot really just go to a hospital and learn that. You have to read the books and just kind of practice. And that's what I did. That's what I did. And eventually I noticed that these patients, this is another topic really, but I noticed that these patients, they have high pressure, not low pressure. So that's rotational obstruction stuff, although it's clearly true because the studies had real evidence. It's extremely rare, like extremely, extremely rare, and it's not a common problem. So now after I learn a lot of the ultrasound stuff, when I was looking at some of the MRIs from some of my patients, I realized that, I'm able to identify a lot of the tissues now just because there are similarities between ultrasound and, the kind of cross-sectional view and MRI. So I figured, I might as well try to learn some of this. I bought some books and I started reading. And the motivation, of course, especially with regards to spinal imaging, I would say, because spinal imaging, like we already talked about that, there's a lot of problems there, a lot of problems with spinal imaging. And I could have patients coming in, with all kinds of neurological deficits and positive clinical exams, and they had normal, virtually normal imaging studies, or they could say that, let's say the patient comes in and they have wrist paresis or biceps paresis or whatever, and the MRI says, mild root stenosis, mild root compression. Yeah, but the patient has paresis, so that doesn't make any sense. So that was my motivation to learn more about this. And I must say that this has been a tremendous, tremendous blessing for my business and for my clinical education. Tremendous blessing. But it's also been frightening in many ways because I realized that I don't even know if I should be saying this, but radiology department is kind of the top of medicine at this point. More or less the top of medicine. And how can the top of medicine also be an organ that doesn't examine patients? It's a monstrosity. It is an absolute abomination. When I talk about radiologists, they hate me. But clinicians, they agree with me, especially a lot of neurosurgeons. I have many, many thousands of doctors who follow my work. most of the clinicians they agree with me that this cannot continue like this because they see these patients coming in with obvious clinical deficit and imaging being deemed as normal. And I said not because, this is important to emphasize, it's not because the radiologists, the doofus or anything like that, it's because how it is set up for failure. Hundreds of scans being done in a couple of hours, it's set up for failure. And the lack of clinical examination, not even talking with the patient, cannot continue like this. For emergency medicine, it might be fine, but for any kind of non-acute imaging, it is simply not fine. It is not okay. So we need to put the finger to this. But that is how I got into the imaging part, basically. So that is my history. So I'm not necessarily, I wouldn't say I'm self-taught but I read the books. I taught on my own initiative, if you will. Now, and it has been a tremendous blessing for me because I've been able to delineate between real and false reporting, obviously, and also having that opportunity to be able to correlate between clinical and imaging. And that also helps you to understand what kind of imaging you need to order. So that, which is why it's not too easy to explain to you how the patient themselves can just know what to get. It's not that simple. You would have to give me like a case. You would have to present me with a case study. And then I could tell you what to order. Does that make sense?
Yes, absolutely.
Yeah.
All going back to finding the practitioner that is invested in learning your body to know what you need.
Here's the best advice I can give you. If you have chronic pain, go get a new MRI, unless you have one from last year or whatever, and go to see a private surgeon within the scope of practice that your problem is, and ask them their opinion. If the first one you see, like, you know, when you talk to someone, you can hear if they know what they're talking about or not. If you're not getting like kind of the answers, they're not sure about really anything in life, yeah, you pass on that and you go to the next guy. But if you meet someone that you feel like this guy really knows what he's talking about, he's showing me everything, explaining me everything, you would just have to trust that, because the likelihood that you, without any real education, I'm talking about the patient now, will be able to get better, find better information than that. I'm not saying it's impossible, but it's difficult, very difficult. Yeah. So instead of getting these repeating MRIs via the general practitioners, go to see a private surgeon. Best way to go. He will examine you. He will look at the images. That's the best way to go, especially if we're talking about spinal problem.
One of the big things is just because, when someone goes in for an MRI or whatever, and they find something, it doesn't necessarily mean that thing is causing this pain. And that's the point. That's the point, is for the individual to recognize that and say, are they taking me along a logical thought process of how all of this is connected? And that's what you're pushing for, is find that practitioner. You may not always understand everything, but is the practitioner you're working with connecting all of the dots, not just, oh, well, there's this, let's take that out or shave that off, or finding the person that can connect all those dots.
And let's say connecting the dots should be especially when we're talking about difficult clinical presentations, complex problems, connecting the dots will often be the job of the patient. Because unless you have a lot of money, you can spend a lot of time with the same practitioner and they really care and they have enough time to help you and expertise about all the differentials.
Yeah.
It's going to be very hard to do that. You will have to make the red dots, the red threads. You will have to follow those yourselves.
Yes.
But seeing the practitioners to exclude each differential or confirm each differential and putting it in the right way, that's going to help you to put the piece of the puzzle together.
And it's very hard to do that when you are in pain, especially when it's nerve, and especially I would assume when there's things around the head. Like I had 2 oral surgeries in the matter of 30 days because of a mistake that one dentist made, a bad root canal, and then a tooth that cracked down to the root. And that's probably, I've had 2 children. That was probably the worst pain I've ever experienced. So I can't imagine trying to keep up with all of those red dots going through something, especially around the head. So my encouragement then is to have a family member or a friend on board with you on this journey, because you literally can't think straight when you're hurting that bad.
Well, first of all, I agree with you. I can tell you this though. you probably see a lot of chronic pain patients. I also do that. And it's interesting to see how much pain people can kind of get accustomed to. Mm. Some people can have 7 or 8 level of pain every day, and they can still present like they're normal in the office when you're talking to them. If it's a 9 or 10, most patients are probably going to kill themselves when they reach that level. But 7 to 8, a lot of people can get to some extent accustomed to that and live with that, which is incredible, actually. The human body has a lot of tremendous adaptational capacity.
And talking about the brain and when we have physical issues and functional issues, obviously it's horrible and it's painful. But when we get to issues of the brain, it's a whole nother ballgame. So can you talk a little bit about, and again, it's a very deep and wide topic, but people, with constant migraines or, just there's another book that I love. It's the brain that changes. It's the brain that changes itself. It's like miraculous healing, but it's actually not miracles. It's just finding the right practitioner that deduces what's wrong with you. For example, one lady all of a sudden lost her balance, was dizzy every day, could not stand upright. Yeah. Just lost everything. And they gave her some clinical diagnosis and said, sorry, this is just how it's going to be. There's nothing we can do for you. She kept pushing and found a practitioner that did some type of therapy with her tongue that did something with her vestibular system, and she could end up walking again. So it was a miraculous recovery, but she just found someone that was willing to try different things and helped her recover. But when you come to issues with the brain and the head, those are tricky and I would assume difficult to work with. Or is it just kind of a more in-depth version of the lower half of the body?
It's complicated. I can give you one example. So head symptoms are often either some kind of acute issue that is chronified, or it tends to be stress-related. And when you're dealing with patients who have psychological, if a symptom really is at the highest level psychogenic, it's going to be hard to treat them. I actually posted a case study today about a relatively young kid who was, I think he's 24 or 25 or something like that. And he had multiple head and neck injuries. I think first time, well, I don't remember the first time, but the second time he dropped like 220 pounds. He dropped 220 pounds with the barbell on the back of his neck, which, caused him chronic neck pain, and some transient spells of dizziness, but nothing sinister. And then he told me he was basically shit-faced. He was drunk, very drunk, and his bodies were carrying him up a stairs. And it drops him, of course, this piece of shit, it dropped him neck first on the stair ledge. Bam, 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 right? And after that, he developed chronic dizziness, like on a boat, constantly. And this guy was not this was a normal kid. This was not an anxiety kid. It was even a paramedic. He's still working full time. So obviously not a mental case, which it often is. Unfortunately, it often is. But this was not one of those cases. So he had all kinds of imaging done. They told him everything is normal with you. You have psychiatric problems. And he's like, no, I don't. No, I don't.
It was dropped on my head, people.
Yeah. But they said, but your imaging is normal. They said, your imaging is normal. And, we're back to, well, is it really normal? I said, yeah. So he went to see the psychiatrist because, fuck it, I will talk to them. And they said, this is not like a psychiatric problem. You're normal. You have a neck injury. We don't know. We cannot fix it, obviously, as a psychiatrist, but this is not imaginary. So he goes back to neurologists. They don't know what to do with him, and back and forth. And he has an upright MRI, and I'm not really going to start too much with upright MRI, although it's generally not a good idea to have one because they tend to overdiagnose you, like not just a little bit, but a lot, overdiagnose you a lot. But he had an upright MRI which showed all kinds of crap, like atlantoaxial instability and all kinds of crazy diagnoses, which are, well, if they are diagnosed in a conventional hospital, that would be bad. That means you're not okay. If it's diagnosed at an alternative clinic, it could mean anything between a moderate problem to, like, we're guessing. We don't really know. All right. Mm-hmm. But he was diagnosed with that. I talked with him and I told him, listen, you probably don't have that because it tends to be bullshit, but who knows? You have neck injuries, let's see. And I examined him and I look at his images, and sure enough, this guy here actually has rupture of several partial ruptures, not complete, but partial rupture of several important ligaments in the craniocervical junction. Bilateral partial tearing of the alar ligament, transverse atlantic ligament, which suggests that this was a very aggressive neck injury that he suffered. Yeah. Now, does that alone explain his symptoms? Well, we could say, here we have some findings. And you could, of course, go to WebMD and look at the associated symptoms, but you should not do that. You should not do that, because piece of paper diagnosis is not the same as looking at associated symptoms. Because to understand associated symptoms, you have to be able to, in detail, look at each element that can possibly make those symptoms. And in this case, there really was no. In this case, although he had some ligamentous rupture, he did not have any grave worsening with rotation, which is really what we're looking for in atlantoaxial instability, unless there is brainstem compression, and here was nowhere near brainstem compression. So I told him, all right, you clearly had a big bang on your neck, and you do have some signs of AAI, but I'm not convinced that this is causing your symptoms, simply because your symptoms are there all the time, and regardless of you moving your neck or not, which doesn't make any sense, right? So we kept looking at this neck MRI and neck and head MRI. And what we found was that, first of all, both of you have two main drainage canals in the neck called the jugular veins, internal jugular veins. And these are pretty thick, calibered vessels that drain deoxygenated, so used blood, they drain used blood from your head. And in either patients with horrible posture, either due to trauma or due to poor self-esteem or anxiety or whatever. It doesn't really matter. The reason doesn't, it doesn't matter with regards to treatment, but with regards to diagnosis, it doesn't. He had obstruction of these veins, at least. Tremendous obstruction, to the degree where we could see on the MRI there was no flow there, because the vessel, when there's good flow, it's black, and in this case it was white. So there was a stasis, what we call a venous stasis. Now, when you have blood coming in and it's not coming out, which is a half-truth, because it also comes out through secondary drainage canals, but they are not of the same capacity, right? You get some degree of craniovascular congestion. And in this case, would that fit with the dizziness and the headaches and the stuff that he's having? Yes, it would. It absolutely fits. And no one had told him, well, this is not true, actually. One neurosurgeon had told him that. He wanted to see a private neurosurgeon, which told him that as well. So that's one thing. And then that's one cause of chronic migraine, chronic vestibular dysfunction that you can look at, are the jugular veins patent. And there are recent studies. There was one study done in 2012, and what they found was that I think it was up to 70%, if I remember correctly, 70% of patients that for whatever reason underwent angiographic imaging of their head, looking at the arterial supply, when they did a coincidental venogram of the head, looking at the venous system, they found that 70% of them had either uni or bilateral jugular venous obstruction, which is very interesting, isn't it? And this is almost never reported. Almost jugular vein obstruction, although it's almost never reported. It's coming now. There's more and more. It's a growing body of evidence on this now. It's growing tremendously, especially since 2016, 2017. But it's not in the textbooks yet. So that's one of the very important things to look for if you have some kind of chronic head symptom. This also causes poor short-term memory. It can cause syncopal events, so you passing out. It can cause very poor cognition, so loss of vocabulary, poor concentration. It can cause tremendous fatigue, which is common also. It's common both in anxiety and whiplash, isn't it? A lot of anxiety and whiplash symptoms, they overlap. And that's because the bracing that these anxiety patients do, it actually causes real physical damage to the body. Bracing causes, if you want to remember one thing I said today, remember this. Bracing due to anxiety or stress or whatever causes real physical damage to the body. We see the same symptoms in whiplash patients, like car accident patients, that we see in anxiety patients. Yeah. Isn't that interesting? Yeah.
Yes.
And although both of these patient groups need treatment for real physiological problems, let's say muscles in the neck or whatever. One group will also need psychotherapy, where whiplash patients usually will not, depending on whether there's premorbidity or not. Right. Psychological premorbidity, yes.
Yep.
So with regards to the head, tinnitus, headaches, fatigue, blurred vision, migraine, all of these symptoms. If I were to give you like a short couple of things to look for jugular vein obstruction. Number one, relatively easy to see on an MRI. CT venogram is the best. Plain MRI of the head is a good start. And then look for thoracic outlet syndrome. Thoracic outlet syndrome is usually a problem that is regarded as a culprit of arm pain, brachialgia, arm pain or vascular symptoms, and neck pain, of course. But thoracic outlet syndrome is also an issue that can cause increased. You remember I talked about this earlier with the ultrasound. It's considered something that can very rarely cause, it's a digression, but to be honest, the literature, it has recited seven, 8 studies, like hundreds of times. So when you read these studies, you get the impression that, wow, vertebral artery damage can be common in these patients, which is absolute bullshit. But that's why I got into the ultrasound in the first place, because I didn't want to kill my patients. What I found was the opposite. When you compress the subclavian artery, less blood goes to the arm. When less blood goes to the arm, more goes to the head. So you have increased blood to the head. And the body cannot really compensate very well for this. It's worse when you lie down, better when you stand up. So there's a big orthostatic component there. But the body, it can dilate the arteries, of course. But that's not, first of all, when you dilate the arteries, the muscles around the vessels, the muscles inside the vessels, those muscles are relaxed. So now you have a greater risk of injury of the vessel, which is not good long term. And then the body can also, and the other thing is that although you widen the vessel, well, there's too much blood coming in compared to what the brain is consuming. So you still get the congestion. So you can compensate, but it's not going to be enough. So you'll just eventually you will have hyperdilation. You can have risk of increased aneurysmic development, or I've seen hemiplegic migraine, for example, so stroke symptoms to half of the body, for example. Many strange symptoms. And then the other compensation that often happens is low heart rate. So the body dilates the cranial vasculature and it dampens the heart rate. And I've seen so many of these circumstances where patient comes in, is like obese, middle-aged lady. There's nothing wrong with that. I don't care about that. But then they say, well, I have beautiful heart rate. My doctor says I have heart rate like an athlete. Yeah, well, that doesn't make any fucking sense, does it, lady? Right? Last time you run, well, I'm not going to go there, but you see what I'm saying. So, and they're often honest about that. I don't understand why, because I don't exercise. And often they have chronic migraine, horrible memory, feel like crap all the time, pain in the shoulders, pain in the shoulder blades, arms, pain in the chest, difficulty breathing and whatnot. You have thoracic outlet syndrome. So they sit there and they have a heart rate of 55, maybe 55 or 50 when they lie down, 60 when they're sitting up. You shouldn't have that if you're overweight and you're 50 or 60 years old. You shouldn't have that, right? So that instead of saying that they're all beautiful, your heart rate and everything's perfect, should raise the question, yeah, but why though? Why is the heart rate so low? It's usually thoracic outlet syndrome. And it's a very common problem. Now, I don't want everyone out there with a low heart rate to think that they're TOS, but if you have horrible pain in your neck and lots of migraines, pain in your shoulder blades, tired all the time, and your heart rate is very low, abnormally low, and you know that your cardiovascular shape is not great, all right, you might have thoracic outlet syndrome. And there are things you can go about to ameliorate that.
That brings up a good question that I have been contemplating for a while. When you're looking at the health of I have people's bodies in my hands every day. I have their craniums in my hand every day. And when you're talking about associating what is the causal relationship between different things, in your opinion, when we're talking about someone's physical being, people that are overweight and have a lot of fat in their body, and also on the opposite side of the spectrum, people that are maybe anorexic or vegan and they're not getting the nutrients they need, do you think those groups of people are more predisposed to having nerve pain?
Absolutely. Okay. Absolutely.
And what can you tell people, because that's a very difficult discussion to have with people, to tell them that the state that their body is in,
they know.
I know.
No, you don't have to tell them. They know.
Yes.
If you are, people listen, this is like a source topic, and although my personality is a little bit abrasive, but I don't really want to hurt anyone, so I'm going to try to phrase it the right way. But if you don't look your best, you're gonna know. You know it. Some people are more sensitive to this, others are less sensitive to it. But if you have a patient coming in and they're anorexic or on the obese side, and they have a ton of problems, and you examine them, they're bracing, they're tucking the pelvis. Tucked pelvis is like the dogs do when they're afraid, right? It's a protective mechanism. Tucking the head down. When you see that dowager's hump, I often see this in obese ladies. It's poor self-esteem. They're pulling their necks down because they know, you know what I'm saying. I don't want to say it, but they know that things are not what it should be, right? So you're kind of hiding up because you don't want to. Yes. There's tremendous body of evidence on this. Poor self-esteem, anxiety, all of these issues. So they already know. And if the patient, I'm not really into the life. I don't have the personality for that, right? I would just hurt people if I did that. So I avoid that. If patient comes, I always treat people like, unless you piss me off, of course, I'm going to treat you like I don't care about your color. I don't care if you're thin or you're fat or whatever. Just be honest with me and treat me with respect. I'm going to respect you and treat you good, right? So, but I don't really go in there. I can tell someone if we're in, let's say someone has high blood pressure, then I will tell them. For their pain, I'm not necessarily going to tell them. But if they have high blood pressure, I'm going to say, look, I'm saying this because I care about you. Your blood pressure is not good. You need to lose weight. I don't want you to, I don't want anything bad to happen with you. You're a good person. I say nice things to them to motivate them, right? Mm-hmm. You have people who care about your grandchildren, blah, 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 right? Yeah. You need to lose some weight. Do it for yourself, do it for them. If they don't listen, I'm not going to scold them. If they don't have the mental capacity to change that, fine. Then, okay, but then you're going to take the beta blockers. Yeah. Like, I'm not going to take no for an answer. You're going to take your beta blockers.
Right.
That's period. You see what I'm saying?
Yeah, absolutely.
So if you have, I think if you have the personality to be like a great life coach, the personality to do that and actually change people, go for it. But personally, I just kind of acknowledge that if they come in, they have a dog or something, they're overweight. I don't really have a lot of overweight patients, but I don't really see that many of those patients because everyone who reads on my website, they say it's very clear on my website, it's all self-work. You have to do the work yourself. The people who just, I don't want to say something wrong, but if you're not willing to put the work in,
there's a pattern of behavior that produces how our bodies are presenting ourselves into the world. So if a person isn't willing to restructure the pattern of behavior that got them where they are now, that's what you're saying is you can lead a horse to water, but you can't make them drink.
Exactly. So when they comment, let's say I have an obese person coming in. And I say, well, listen, I'm not going to comment. I never comment on their habits. I never do because I don't give a fuck. I don't care. If you want to be fat, be fat. I don't care. Like I have my own shit to deal with. But do my homework. Like do my fucking homework though. So I tell them, listen, if they're fat or not, I don't care. Have a nice neck posture. Don't brace. Like don't go around holding your breath and bracing your abdomen and clenching your butt because that's fucking up your hips and your neck and all your body. Like if they come in and they're fat and they do my homework and they do everything beautifully, I'm happy. Taste is better. Didn't lose 1 pound. I'm happy. I don't care. I got them better.
But they probably will start to, because when they start to feel better, they start to do better, which starts that domino effect of change, which creates different results. Yeah. And
let me tell you, if that's the truth for many of my patients that I've had in the past, that they came and got better and it had a domino effect, I'm super stoked for them. Awesome. Very happy for you. Yeah. A lot of, unfortunately, in my experience, a lot of the times when patients come in and their issues, I'm not going to say this is everyone. This is not everyone, but if your posture is really, really horrible, you always have, when you get a patient in that has some kind of psychiatric pre-morbidity, you got to ask yourself, what is the likelihood that I'm going to be able to treat this person? And especially with my personality, I always ask myself that, because I see, it's kind of ironic or whatever, but I see a lot of these anxiety patients and they hate me. Yeah, they hate me because I'm rough with them and they cannot tolerate that. But I always ask myself, what is the likelihood that I can treat this patient? Because I always separate between the rational anxiety patient and the irrational anxiety patient. The rational one, you can explain them logic and then we'll ask questions back and forth, but when they get it, they get it. The irrational patient, they're always going to be sitting there like, yeah, but maybe this is wrong. Maybe he's tripping me. Maybe I got something wrong. They're always back and forth in their minds. These patients, I have like very low, very, very low clearance rates with these patients. Yeah. Very, very, very low. So I always ask myself, what's the likelihood I can treat these patients? And I evaluate, I do like a rough evaluation of their psychological state, I would say. And I basically base that on the questions that they ask me. And if I answer their question, but they keep asking it. But I answered your question very clearly, and I know that you heard my answer. And they keep asking it, that makes me suspicious that this is an irrational anxiety patient. I could be wrong, of course. And some people are going to be offended when I hear this. I don't really care, to be honest, if they are, because I'm not saying this to be an asshole. I'm just saying this to kind of screen out who I can help and who I can't help.
Right. Oh, right? I'll give you a simple example of that with myself. I am a solo practitioner. I do not have a secretary. My schedule is live. It is accessible by my clients. And when I have people that want to call me or text me for an appointment, I'm like, no, I don't do that for people. No, I don't babysit. If you don't have the capacity to go on the website and schedule your appointment, you aren't the client for me. So not only as individuals do we need to research and find that practitioner that we can, associate with and be compatible with, I'm testing you because there are 10 other people on my waiting list that want that appointment that are going to get more out of it and benefit from it. And if I can't even get you to schedule your own appointment, then we're not going to be a good client therapist relationship to start with. So 100%. There's many different examples like that. And our time is, like you were saying earlier, our time is very valuable, and we have people that are ready and willing to make these changes and to get better. And those are the people that we want to be spending our time with. And if that is not you, then maybe it's just not the right time. Maybe you aren't ready to heal. If it's not the right time, then don't waste your time or mine and wait until you are ready to show up and do the work.
I agree with you. In that regard, for me, I think it's more like I don't want my everyday life to be annoying. I want my everyday life to be as smooth as possible. Like all kinds of annoying things you could, a lot of people say that my customer service is certainly not the best. And, to be honest, I don't care. Like, it is what it is. I don't have a secretary like you. I don't have time to sit and fucking SMS and email all day. I don't have time for that. If you have a lot of questions, book a session. If you can't afford it, okay, go to see someone else. I cannot deal with that. And the same is with, if you come into my office and you're doubting everything I say. Like, listen, I'm not God. I could be wrong. But I don't have the mental capacity to sit and deal with this over and over. I will give you my reasons. Like, this is why I think what I think. You take it or you leave it, buddy. That's how it works. Yeah. If you don't have any confidence in what I said, fair game. Go to see someone else. No problem.
So it's interesting. It's interesting because my last podcast was with a psychotherapist, and she was explaining these people. She was on the victim profile. They are in that defense mechanism, and no one is going to be able to help them. They're walking in with, I've already seen 5 people. They've tried everything. I'm only here because this person bought me a gift certificate or told me I should come. So you can't help me. And so then we're like, well, no, I can't help you. And this isn't going to happen. So I have ended a session before I ever started before, because I said, you're obviously not ready for this session to work and it's not going to end well. Why don't you come back another day or don't come back at all? I have had to have that conversation before. And that's the psychology behind some people's pain pattern is they have to be on board. They have to be on board. And they have to be ready. So everyone listening, you have got to hear for a few minutes the practitioner side of dealing with individuals on many different levels and capacities. And we have to be very choosy on who we work with.
You know, and it's interesting, you know, I'm sometimes I also make mistakes because usually, this is usually true, not always, of course, not always, but usually my experience is that the more emails and bullshit I get pre-session, the less results I have with these patients.
If I have to scroll up the email more than twice, I'm like, this is going to be a problem. This is going to be a problem. Very common.
Usually,
or they're seeing 5 practitioners at the same time. Like, not going to work because you're waiting for us. You're waiting for one of us to fix you, and that's not possible.
In cases like that, I'm fine with giving a second opinion, but doing the actual treatment, I'm going to tell them, listen, if you're going to do this, if you see other people, if I'm going to have to argue with you about it, that's not going to happen. If you see other people and they just do some stuff that I don't care about, that's fair.
Right.
You're going to do your homework and you're not going to do things that oppose with what I'm telling you. If you can deal with that, it's fine.
Yep.
Or if it is opposing, I will say, listen, I can give you a second opinion, but I'm not going to treat you because it's not going to work.
Right. Yeah.
But I want to say a couple of things about, you know, this is more practitioner to practitioner, maybe some patients will like this, but it's interesting. I found that the more bullshit you get, you know, the more all of this stuff, right? And back and forth, but like, how do I find your website and where do I pay and stuff like that? Come on.
Yeah.
If you cannot find this on your own, then I cannot help you.
Yep.
But I have a couple of times where I can get this kind of email, and I'm like, oh, it's another one of these, right? And I tell them, like, book a session, and immediately book like session for $1,000. And I'm like, all right, I misjudged this. This doesn't happen so often though, but I also seen circumstances where I misinterpreted the intention of the patient. Actually, they just had a lot on their heart, but they have no problem paying and actually very respectful, nice patients. Usually not though, usually it's the other way. But I have seen that. I had one guy, he insisted on calling me, and I'm like, I have a lot of foreign patients, like outside of my country, a ton of them. So I don't really do foreign calls because I would be getting fucking called down, you know, all hours and whatnot. I usually say no. But this guy, he kept insisting, you know, I want to call me about my son and whatnot. I said, don't call this poor guy. And I chatted with him for like 7 minutes, and he booked, like, he pre-ordered like 20 sessions on my website. It was $2,000. He just wanted to, you know, to have like a talk to kind of see who you are. And usually, you know, it's just sad because usually you end up wasting time when you do that. But then sometimes it's the real deal, and it's really hard to know. And I've had several incidences where I've been very short answered, and it turned out to be a very, very nice session.
Yep. And that's the human capacity of it all. We can't ever be always right, but there are ebbs and flows that we have to be aware of. And then there's the occasional, it's interesting to be.
I talked with one TMJ patient. There's a clinic in England. Do you know who Dr. Mike Mew is?
Mm-mm.
He's like an orthodontist, like facial development stuff. And Mike Mew, he's a nice guy. He's my buddy. He's not very good at answering emails, and certainly not these kind of emails. And I had a consult with a patient, and the intake form was like this, but I was like, fuck it, he paid for it, probably. He paid for my time, right?
Mm-hmm.
And turns out he had been sending this clinic like 2 or 3 emails, and he never got a response. And this guy had no problem paying. Like, he was eager to pay. He just wanted to talk first. And I told him, listen, send another email, send this amount of text, and you say, I want the session, I want to pay, I have a lot of questions. That's what you say. And then you ask the questions in session. Because, you know, when you get these lists of stuff, you're like, I don't have time to deal with this in my free time.
Yeah.
But at the same time, you have to give the client an actual opportunity to show that. Just book a session, and we'll talk about this.
Yep.
Which is fair. Yeah.
Yeah. It's a give and take on both sides. Like, we both have to give each other leeway to show who we are and what we're there for, and then from that information make decisions. So in closing this episode, and it was amazing, a lot of information. I think people are going to be researching a lot, hopefully, for their own
Hope so.
situations. But just a couple of things could you give people that do find themselves in a situation where they're having to go get imaging done? What's a couple of questions they can ask to determine, is this person I'm working with the right one, or just some advice on those initial consultations?
The best way to do that is to go see a surgeon. Don't see this is like I talked about earlier. Surgery is the last resort. No, it depends on the prognosis of the problem. Let's say you have moderate neck pain, but it's every fucking day and it's making you crazy. It's not, you're not killing yourself out of the pain, but it's just making you crazy. Let's say you have an MRI, and this is usually not on the MRI report. It's usually going to say there is root stenosis. Usually the grading of the stenosis tends to be wrong in my experience. I see few. Yeah, I have to say that. I see few radiologists getting it right. And why don't they get it right? Because they don't examine patients. You have to examine patients and do strength exams to be able to grade these things properly. So usually the grading is not correct. And the other thing is that we have to differentiate between disc matter crushing the root. This is an important takeaway. Is there disc matter compressing the root, or is there arthritis compressing the root? Because how the fuck are you going to treat the arthritis? If there is arthritis in the root outlet compressing the root, how are you going to treat that, my friend, with conservative treatment? Can you train that away? No. Can you inject it away? No. It's very easy to scrape out surgery, Simple procedure. Simple procedure, amazing results. So if there's high clinical correlation, send that patient to surgery and do PT afterwards. Simple procedure called foraminotomy. So determine, this is very important. If you have low back or you have a neck pain, find out, people listening can write this down. It's very important if you have neck pain. Is there disc lesions? Are there disc lesions or arthritic lesions compressing the root? Very important. And then another thing you can know for neck imaging is that in the neck images, to really see if there is arthritis or disc matter compressing the root, it's very hard to see from the cross-sectional images, the axial plane. So you need that something called sagittal oblique, where you're looking at the 45-degree angle to really differentiate between arthritic lesions and a disc lesion. If it's a disc lesion, even if it's a big one, let's say, and there's no risk for paralysis, which there usually not, all right? This can heal with conservative treatment. It usually heals on its own. As long as you don't break and stuff like that, it tends to just get worse. If there's arthritis there, no. I had a guy come in, he was just 35, something like that, 35 years old, with chronic neck pain and chronic mild right-sided periscapsular pain. When you have pain between the shoulder blades, it's usually either thoracic outflow syndrome, like mild TOS, or it tends to be C5 or C6 root lesions, root compression. So he went to his GP. His GP did this kind of generic bullshit test on him. He said, well, you don't have a strength deficit. I'm not going to send you to an MRI. Now, this patient, he said, look here, I pay a lot of fucking taxes. You're going to make that MRI. I had paid for 5 years. There's no question. You're going to make that MRI. And he mumbled and rumbled a little bit, but then he ordered the MRI. So this guy comes to see me before he got the report, and I looked at the images, and sure enough, he had a disc lesion there, a hernia, and there was aggressive compression of the nerve root. Not mild, there was aggressive compression of the nerve root. Yeah. So I examined him, and he told me, well, I don't have weakness. He was a CrossFitter. I don't have weakness.
Of course, they say that. Of course, a CrossFitter says they don't have any weakness.
Let me tell you why. Because usually, if you have a C6 lesion, you're usually also going to have weakness of the biceps or your grip along with the wrist, because the wrist is really, the typical sign, extension weakness, typical C6 weakness. So in this case, they did this genetic testing on him, which was normal. So I always do the myotome exam. And that's an important thing also to say. If you have been told that there's nothing wrong with you, go to someone that does a proper myotome examination. I will tell you how to do that. So for the C5,
you have a post on that, don't you? You just posted that. Yeah.
Lots of stuff
I'll put a link to it.
Yeah. You basically go over each myotome, right? C5, shoulder abduction, so on, wrist extension, biceps, finger opposition. And in this case, it was only weakness of the wrist, and that's not something, and it was severe weakness, by the way, of the wrist. But this is, as long as your grip is strong, this is not something that's so obvious to feel unless you're paralyzed and you have a wrist drop. So he was very weak in the wrist. He had paralysis of the wrist, actually, but he could not feel it. And he was shocked when I showed him this. And when I looked at the MRI, because he was first of all told that there's no weakness, there's no reason for an MRI. Wrong, right? Wrong. The examination was not done properly. And then when we saw the MRI, the question is, well, is there just a disc hernia compressing the root? Which, fair enough. You can heal. You can certainly heal. Or is there a combination of disc and arthritic lesions compressing the root? And in this case, there was like a beak of arthritis. Half the lesion was a beak of arthritis. And then the remaining was a couple of millimeters of a disc lesion there. And I told him, listen, you've been in pain for 5-6 years over this problem, and you have paralysis of the wrist. It's going to be up to you. But in this case, if I was offered surgery and I had this problem, I would certainly consider it. And for some people, they would say, no, that's the last resort. Well, how are you going to cure this conservatively? Are we just going to wait until it's a huge problem? I prefer to go to a new contact. Well, there's risk, no risk. Yeah, well, there's a saying that is 20% of the surgeons make 80% of the mistakes. That's why you go to see, we don't like to talk about that, right? That's an unpleasant thing to talk about. But that's why you go to see someone who has a name. You don't go to see a generic person. You go to see someone who has a name. I hope I can't be sued for saying this, but it's fucking important. It needs to come out.
Yeah.
It needs to come out.
Absolutely.
You go to see someone that has a name, that you preferably someone that has a lot of good reviews and so on, and you go to see them. They examine you, look at your images, and then if you go to see a very good surgeon, risk of something bad happening there with endoscopic treatment is very low. It's very, very low, or let's say a ADCF or whatever, very low. Whereas coming in 4 a.m. with horrible pain, surgeon hasn't slept, and cup of coffee and let's go. Yeah, the risk of problems much higher.
Yes,
it's better to do something under planning. So, as I said, you need to know how to differentiate between arthritis and disc lesion. Disc can heal usually. Arthritis doesn't heal. So if it's a big problem and there's clinical correlation over a long time, and there's arthritis, it's better to get that shape down with a foraminotomy. And then always check the strength. Check each myotoma. It's very important. So that's probably how I would go about to get that done. Like I said, go to see. Don't have the mentality that I want to go to see the surgeon last resort. Of course, you got to stay away from people that have this sharp mentality that they want to operate everyone. You have to stay away from those people. You need to find someone who is honest. So that's going to be on the shoulders of the patient. They have to make the research there themselves. But find a reliable surgeon, or even better, maybe the therapist has someone they cooperate with, but that they trust. Can you please look at this and let me know if I'm a surgical candidate or this is a PT problem? Very important. Proactive
would be the way I would sum all of that up. You as the individual have to be proactive and involved.
Yes. Yes, yep. Indeed. Yes.
Awesome. So I will have obviously you're not in the States. So my client base and listeners are all in this area. So you do consultations online via Skype or Zoom or whatever. So people can reach out to you and share their images and get second opinions and just determine with more intellectual contribution their next steps by talking to you that way, correct?
Indeed, yes. Now for that, I'm moving to South America, by the way.
Wow.
Yeah, so that's probably still a far way to go for most
Carolinians.
Yeah. But
that is
South America.
That's exciting.
Very exciting. So I'm looking forward to that. It's going to happen this spring, I guess.
Good.
But yes, I offer Skype consultations. About $130 for a consultation. Yeah.
I think if anything has come out of all the COVID craziness is it's pushed us into other areas of comfort, which is I don't have to stay in my little bubble and in only the people that I know for my care. And it's making us more, receiving of different forms of care, different forms of treatment, connections and relationships. So I hope that I refer you to my clients all the time. I don't know if anyone's took you up on it, but I let them know that you're available. So I hope that they will start to contact you, because that's not my specialty. I know my specialty and I stay in my lane. That's an important thing for people to do.
I think at least staying in the lane is fine. And then if you want to get out of the lane, that's also fine. But then you have to do it the right way, I think.
Yeah.
By acquiring the right knowledge. And I think that a lot of people are saying, for example, well, no, you don't need surgery. They don't know what the fuck is happening.
Right.
So, but in many, being in the lane, that's fine. Getting out of the lane, also fine if you acquire the necessary knowledge. So, which is, both are commendable actions. So very nice. Mm-hmm. And it sounds to me that your patients are in very excellent care. So well done on your behalf.
Thank you.
Good.
And you as well.
Than my patients. Well, I don't know about that.
We are who we are supposed to be, and if we need to learn along the way to be able to communicate with people in a different way, but our personality is what it's supposed to be. The world needs you as you are, and the world needs me as I am. Yeah.
Yes, I'm convinced that the world needs me. And it's interesting, I have, with my personality, when I click with a patient, then we really fucking click. Like we're best buddies now. So
everyone can't be strawberries and butterflies all the time. That we don't need everybody to be like that. So I highly appreciate different types of people, because if I was around the same type of people all the time, it would be really annoying. So keep being you, Mr. Larson. I'm still not going to say your name.
You can do
it. Thank you so much. And I'm sure we'll talk again soon. Thank you.
Have a great night.
Thank you. Bye.